Hi everybody, welcome to DigiPath Tutorials. Today we are going to discuss FNAC diagnosis of Leishmaniasis in lymph nodes. A 15-year-old female presented to our laboratory with enlarged veinless left-sided cervical lymphadenopathy for the past 5 years. Multiple FNAC reports done at various outside laboratories offered diagnosis of reactive hyperplasia. Here you can notice that the patient has enlarged cervical lymph nodes. We performed an FNAC again at our laboratory since it was persistent. On low power magnification of the smears, we see a reactive lymphoid population showing various small lymphocytes as well as slightly larger lymphoid cells. And what is striking in the smear was that there were numerous histiocytes, which are these larger cells with the pale cytoplasm and the round to oval bland nucleus. In other areas of the smear, we noticed that there were numerous plasma cells, which are these cells with the eccentric nucleus and the dark blue cytoplasm. We also noticed that within a few histiocytes, there were some aggregates of some structures. In other areas, we could also appreciate some granulomas, which were composed of some epithelioid-looking histiocytes as well as lymphocytes. On higher power, we can appreciate that within the cytoplasm of the macrophages, there are numerous organisms. Here is one, and here is another. So these organisms have a nucleus, and then you can appreciate that there is a sort of a flare of a cytoplasm. In this one, you can also see that there is a kinetoplast. Here again, we can appreciate another organism within the cytoplasm of the macrophage. Again, you see numerous organisms within the cytoplasm. And in this field, we can see an organism, if you look closely, and it has a nucleus and another sort of a dot. So these are the amasticote forms of the Leishmania parasite, which are also known as LD bodies. In other areas, these organisms were also seen to lie extracellularly. Based on these findings, a diagnosis of Leishmaniasis was made. Leishmaniasis is a vector-borne disease caused by an intracellular protozoan parasite of the genus Leishmania. It is transmitted by the bite of an infected female sandfly of genus Phlebotomus or Lutzomia. Very rarely, Leishmaniasis has also been known to be transmitted by blood transfusion, congenital infection, or accidental inoculation through culture media. Leishmaniasis has been associated with malnutrition, population displacement and travel, poor housing, weakened immune system. It has also been seen in association with many patients of HIV and environmental changes such as deforestation and urbanization. Leishmaniasis is endemic almost throughout the world except in Australia and Antarctica, and in India, Leishmaniasis is endemic in the states of Bihar, Jharkhand, West Bengal and eastern Uttar Pradesh. The parasite exists in two stages, an amasticote form and a promasticote form. The amasticote form is aflagellar. It exists in the vertebrate host, which in this case is humans. It has a round to oval shape. Here we can appreciate that this is a macrophage, and within the cytoplasm of the macrophage there are numerous amasticote forms of Leishmaniasis, also known as LD bodies. So here we can see that the red arrow is pointing towards the nucleus of the amasticote, and often perpendicular to that is a small body known as the kinetoplast, which is demonstrated by the black arrow. So this constitutes actually the amasticote form of the Leishmanian parasite. Over here we see the promasticote form of the Leishmaniasis, which is composed of slender spindle-shaped organisms. These again have a nucleus and a kinetoplast. These are flagellated and they occur only in the sandfly and in culture media. We look at the life cycle of Leishmaniasis briefly. We have a vector, which is the sandfly. Now, this injects the promastigote form of the parasite during a blood meal for in the humans. These promastigotes are phagocytosed by macrophages and other mononuclear phagocytic cells at the site of the bite. Further on, they transform into amastigotes, and these amastigotes multiply in cells of various tissues, primarily the reticuloendothelial system, and infect other cells. Again, we come to the stage when the sandfly takes a blood meal and it ingests macrophages infected with amastigotes, which are then ingested. These amastigotes transform into promastigote stage in the gut of the sandfly, and then they divide and migrate to the proboscis of the sandfly, and then the cycle continues. Leishmaniasis can cause cutaneous, mucocutaneous, and visceral disease. Human infection is caused by more than 20 different species of the genus Leishmania. These species are broadly divided into Old World, which includes tropical and subtropical Asia, India, Africa, and Mediterranean, and New World species, which is predominantly in the Americas. Now, Old World species include species like Leishmania donovani, Leishmania tropica, Leishmania infantum, and Leishmania major. And New World species include L. brasiliensis, L. mexicana complex, and L. chagassi. The clinical presentation and prognosis in the patients vary based on species, duration of infection, and the immune status of the patient. The cutaneous form of the disease can be caused by both Old World and New World species. The lesions are usually restricted to the face, scalp, arms, or other exposed areas. The cutaneous form can be localized or disseminated in case there is a weakened immune system, recurrent, or post-Kala Azar. This post-Kala Azar actually refers to the dermal form of leishmaniasis which develops after visceral leishmaniasis. The mucocutaneous form of the disease occurs when primary cutaneous infection by New World species like L. brasiliensis is left untreated or suboptimally treated. In this case, then the infection can become disseminated to upper respiratory tract, producing lesions of oral, pharyngeal, or nasal mucosa with ulceration and mutilation. Visceral leishmaniasis is also called Kala Azar. Actually, this term refers to black sickness. It is caused most commonly by species like L. donovani and L. infantum. In this form, the parasites spread throughout the reticuloendothelial system of the body, causing fever, malaise, weight loss, hepatosplenomegaly, anorexia, pancytopenia, hypergammaglobulinemia, and hypoalbuminemia. It usually spares skin except for irregular areas of dark pigmentation, and it can be fatal if untreated. So, what do we see on FNAC smears? Basically, it would look like a reactive lymph node showing a polymorphous cell population, but there will be a prominence of histiocytes and plasma cells, which should give you a clue that you need to look for these bodies. You can often have non-necrotizing granulomas, giant cells, and you then can appreciate intracellular and extracellular LD bodies or the amastigote forms of the parasite, which can be seen within the histiocyte cytoplasm or they can be found lying extracellularly. As discussed before, the amastigote forms are small round to ovoid structures of 2 to 5 micrometers in size with a fine membrane. They possess a central round nucleus and a rod-shaped kinetoplast. The kinetoplast actually contains the mitochondrial DNA of the parasite. Now, these LD bodies can sometimes be confused with platelet aggregates, but platelets are always extracellular and they are often mostly only found in clumps or aggregates. And they also lack a kinetoplast when we see the structure on higher power. For LD bodies, the positive stains include GMSA, HNE, and Wiegert's iron hematoxylin. On GMSA, the organism stain intensely blue. When we come to the differential diagnosis of leishmaniasis, we need to keep two things in mind. One is histoplasmosis and the other is emperipolysis. Now, histoplasmosis often causes confusion with leishmaniasis because the yeast forms are often of a similar size to the Leishmania A mastigote. However, unlike leishmaniasis, histoplasmosis, being a yeast, can demonstrate narrow-based budding, and it also stains with silver stains and pus. It also shows a periorganism halo and lacks a kinetoplast. Here in this picture, we can see numerous histoplasma with a periorganism halo. The second thing we need to keep in mind is emperipolysis. Now, emperipolysis refers to the engulfment of an intact cell by another cell. Here in this picture, we can appreciate there is a macrophage and it has numerous engulfed intact lymphocytes within phagocytic vacuoles. These also need to be kept in mind before making a diagnosis of leishmaniasis. The diagnosis of leishmaniasis can be established from peripheral thick blood films, bone marrow aspirates, lymph node aspirates, spleen, or skin biopsies. So we can either identify the parasites on HNE or in cytology smears. The parasite can be cultured on NN in agar. We can do PCR, but PCR results can sometimes be false positives. Fluorescent antibody tests using the patient's serum, or the intradermal delayed hypersensitivity test, or the Montenegro or Leishmanian test. But this test, we should remember, can be negative in forms with cell-mediated immunohyperreactivity, such as the diffuse cutaneous and visceral forms. So the take-home messages from our case would be that although leishmaniasis is a rare cause of lymphadenopathy, it should be considered as a differential diagnosis, particularly in endemic regions. And on the smear, if we see numerous histiocytes and plasma cells and certain intracellular or extracellular structures, we should have a heightened sense of suspicion for LD bodies. So, cytology is an excellent tool for the diagnosis and management of leishmaniasis. We have more digital slide sets available for histopathology and cytology on our server. So, please subscribe and have a look at them. You can also follow us on Twitter at the rate Dr. M. Chandra _MD. Thank you.